So as we're looking at our skeletal system, we have a lot of joints. Joints are movements, or areas where we have movement. Sometimes movement is a relative term, particularly for fused joints, or if we have a fused suture, there's going to be nearly no movement. As we're looking at our skeletal system, this movement is going to allow for the skeletal system to perform its necessary functions. And of all the joints that we have in our body, the synovial joint, also known as the diarthroses, is what we traditionally think of as a joint. It's the most commonly thought of, it's the most flexible, it's the joint that when you ask someone to move their joints, this is what they're going to move. They can have voluntary, conscious control over moving their synovial joints. The synovial joints are typically going to be controlled by skeletal muscle tissues. And because these joints have the most degrees of freedom, they have the most ways that they can move, these joints need to be really complex to maintain structural integrity while allowing for so many degrees of freedom of movement in the X, Y, and Z planes, or depending on the joint, maybe just the X and Y, or maybe just the Z plane. As we're looking at these degrees of freedom, we need to have a lot of structures in place to allow for structural integrity and freedom of movement. Because these joints are the most complex joints that we have in our bodies, these are the joints that are most likely to have malfunctions. The more parts there are, the more likely there is for something to go wrong. So let's talk about the parts of a generic synovial joint. At the end of our bones, we have that cartilage that's left over from the endochondral ossification. That cartilage in the synovial joint is referred to as the articular cartilage. And as we look at the articular cartilage, in healthy individuals, it's about 2 to 3 millimeters thick, and it serves a very important purpose. It reduces friction in the joint. The primary purpose of that articular cartilage is to reduce friction. It's very smooth, it's made of hyaline cartilage, and it's very slippery. If you ever felt the articular cartilage on a chicken wing or a chicken leg when you're eating chicken legs at Buffalo Wild Wings, you notice how it's very slippery when you bite into it. We find that this articular cartilage, while its primary purpose is to reduce friction, there's a secondary purpose. It's kind of squishy. It has a little bit of springiness to it. Not as much springiness as fibrocartilage, but it still can help to serve as a shock absorber. So that's a secondary function of the articular cartilage. As we're looking at the overall space for the joint or articulation, that overall space inside of the joint is referred to as the articular cavity. I'm going to cover that articular cavity in blue, and that's going to be the space in between articular cartilage within the joint. And within that articular cavity, within that joint cavity, we're going to have a liquid. This liquid is known as synovial fluid, or to continue a bad joke, if there was such a thing as elbow grease would literally be synovial fluid. And as we look at synovial fluid, it has hydroluric acid. Hydroluronic acid is a glycoprotein that has branching carbohydrate chains on it. And these branching carbohydrate chains will absorb water molecules via hydrogen bonding. And because it absorbs the water molecules via hydrogen bonding, it makes this liquid very slippery. Albumin is another common protein that's present within synovial fluid. The most common source of albumin you've probably experienced is the egg white of a chicken egg. So the next time you're making scrambled eggs, shove your fingers in the egg white and just kind of feel how slippery those egg whites are. Both the albumin and the hydroluronic acid are going to give the synovial fluid a little bit of viscosity and a high degree of slipperiness. So in other words, it's kind of a thick liquid that's incredibly slippery. And as we're looking at this liquid is how we deliver most of the nutrients to our articular cartilage. Think back to when we covered histology. Articular cartilage is hyaline cartilage. It does not have blood vessels. It is avascular. So in order to get nutrients to this cartilage, we're going to have to do something abnormal. And what we end up doing is delivering the nutrients to the synovial fluid, and then as you compress the articular cartilage, it's kind of like squeezing a sponge. And compressing the articular cartilage will wring out fluid, and then when you remove pressure, it swells back up again. And as you compress and swell your articular cartilage, it will absorb nutrients from the synovial fluid, and it will release waste products into the synovial fluid. As we look at the joint as a whole, we're going to have a tough fibrous membrane around the outside. That tough fibrous membrane around the outside is referred to as the joint capsule. This joint capsule is going to be a two-membrane enclosure. The outer part of the joint capsule is known as the fibrous capsule. This is going to have a high concentration of collagen fibers, and this is very difficult to cut through. If you're interested in the particular histology, it is dense, irregular connective tissue that makes up the outer fibrous capsule. As we look at the inside of our articular capsule, we're going to have another membrane, and the secondary membrane is known as the synovial membrane. Its primary purpose is to produce synovial fluid. So within the joint capsule, the outer membrane is the tough protective membrane. The inner membrane produces the lubricant. Now, as we're looking at our joints, some extra special joints, have extra pieces in them, extra complications, like the knee. The knee is one of the most complex synovial joints in our bodies, and as we're looking at our knee, it has pieces of fibrocartilage in it. These pieces of fibrocartilage are to serve as shock absorbers. We also are going to have pieces of fibrocartilage in our back, in between our vertebrae. These pieces of fibrocartilage in our back are referred to as the intervertebral discs. I'm pretty sure I mentioned this during the skeletal system, but it's worth mentioning again. These pieces of fibrocartilage absorb water when we remove pressure from them. And as you lie down horizontally at night, the intervertebral discs in your back will swell up with water, and you'll be about a half an inch taller in the morning compared to when you went to bed that night, because your spine stretched out as it was filling or swelling with water within its intervertebral discs. The special name for fibrocartilage in our knees is referred to as the meniscus. We have both lateral and medial menisci. It's very common to tear the meniscus, particularly an ACL injury paired with either an LCL or a PCL injury will often have the meniscus tear on the side. 20, 30 years ago, to treat meniscal tears, it was standard practice for orthopedic surgeons just to remove all of the fibrocartilage from the knee. The issue behind this was that if there's a piece of fibrocartilage floating around in the knee that's partially torn, occasionally it would cause the joint to seize up and lock up. And that individual would be walking, and then suddenly their knee would stop moving, they'd have shooting pain shooting up their legs, and they would typically fall to the ground. It's been found, though, that it's good to have fibrocartilage in your knees, which is probably why it's there in the first place. So there's a more conservative approach now to treating meniscal tears, and this more conservative approach is to trim the menisci. So if there's a tear, the flap of fibrocartilage is now removed, but the rest of the fibrocartilage will be left in the knee. The untorn portion of the meniscus will be left in the knee. This is clinically significant for you because this change in surgical techniques occurred in the early 80s. So most of you will be in the career field in, like, we'll say 2 to 4 years. You'll be working in healthcare. And there are many, many individuals in their 50s or early 60s who have early onset arthritis of the knee because they had their fibrocartilage pads, their menisci removed. And for younger individuals, myself included, it's now trimmed so they're less likely to develop that arthritis. in the knee. Now, in addition to serving as a shock absorber, and I can't emphasize this enough, our menisci are the shock absorbers. When we think fibrocartilage, I want you to think shock absorption for fibrocartilage, particularly with the intervertebral discs and with the menisci. But there's some secondary functions as well when we look at the meniscus and how complicated the knee is. These fibrocartilage pads help to guide the condyles of the femur and keep them aligned with the condyles of the tibia. They help to keep everything in sync with each other. And as we look at these menisci, in addition to helping the bones fit together, they reduce the chance of dislocation. To dislocate your knee will probably result in tearing the meniscus. You have to physically glide the condyle of the femur over the meniscus in order to separate the femur from the tibia. There's some other secondary accessory structures of our joints, such as bursa. When we think of a bursa, this is clinically significant because a lot of people will develop bursitis. When we think of bursitis, that's an inflammation of the bursa. The bursa itself is going to be a sac filled with synovial fluid. And what does this sac do? It helps to separate tendons that are grouped together that are passing over bones. The most common bursa in our bodies is going to be inside of our wrists. As we look at all of those muscles of our forearm, those muscles of our forearm are going to have tendons going across the wrist, connecting to the carpals, the metacarpals, or the phalanges. And to allow for those tendons to slide easily, we are going to use bursa within our wrists that allow for the smooth movement. On this figure, our bursa are colored kind of teal or aquamarine, and I'm circling them in blue. There's another secondary structure known as the tendon sheath, and this tendon sheath helps to contain the bursa and give it structural support. But there's a double-edged sword. Yes, the tendon sheath keeps the tendons within a bursa grouped together, but it also is pretty inflexible. It has a high concentration of collagen. It's made of that dense, irregular connective tissues. And as we look at the tendon sheath, if there's inflammation of the bursa, the tendon sheath makes it so that there's nowhere for the bursa to expand. A common ailment in our digital age is carpal tunnel syndrome. And in those situations, there's inflammation of the bursa of the wrist, but the tendon sheath of the wrist makes it so that that bursa has nowhere to expand. So the bursa is swelling up and then pinching off within the bursa of the wrist. The most common treatment for carpal tunnel syndrome is to physically slice the tendon sheath so that there's room for the bursa to expand, swell, and then heal, and then contract again for the inflammation to leave. This is absolutely review, but I need to say it again. It's very, very important. This is one of those big take-home ideas I hope you remember 10 or 15 years from now. Tendons connect muscles to bones. Ligaments connect bones to bone. One of the healthcare providers for my children, when I went in for a 6-month checkup, didn't know the difference between a tendon and a ligament. I don't even remember why it came up in conversation, but not knowing the difference between a tendon and a ligament is a great way to make your patient feel uncomfortable. Actually, on that note, another way to make your patient feel really uncomfortable is to Google an answer in front of them and then read off the first result and say it authoritatively from WebMD. At least go to another room so they don't see how you just have no idea. And yeah, I'm speaking from experience. So let's talk about exercise. The old school train of thought is that it's not the years on the car, it's the miles on the car that count. And you know, when buying an automobile, I'd say, generally speaking, that's pretty true, particularly if you're buying an automobile that doesn't get exposed to road salt. And that analogy was used all the time when referring to synovial joints. But that analogy has been found to be incorrect. If individuals are sedentary and they don't exercise or they don't move their joints, and I'm not talking about like grueling exercises that make you want to throw up, but I mean if you don't move your bodies, we don't compress that synovial joint. We don't compress the articular cartilage, and we don't circulate the synovial fluid around the articular cartilage. This moving of the synovial fluid, the warming of the synovial fluid, and the compression of the articular cartilage increases the rate of nutrient exchange between the synovial fluid and the articular cartilage. And if we have a higher rate of nutrient exchange, we can have a higher rate of tissue repair. Mild to moderate exercise actually improves joint function. I know there are a couple individuals in class who are struggling with these kinds of issues, but it's kind of a catch-22. Individuals that have a lot of joint pain will have pain when they move their joints, but then have even more pain when they sit still for a very long period of time. So for most individuals, we find that there's a happy medium where there's a little bit of movement, minimizes the pain, and gives them optimal health. So as we're looking at exercising, it warms the synovial fluid, it causes the cartilage to swell up. Swollen cartilage is a better shock absorber. That compression and flexion, or compression and extension of our synovial fluid increases the rate of metabolic waste exchange. We find that individuals that don't have regular exercise have a higher rate of loss of articular cartilage than individuals who get that mild to moderate exercise. But, there can be too much of a good thing. Individuals that go to an extreme, if you are running, 18 miles a day barefoot, or if you're repping 400 pounds doing power squats every other day, that's the other extreme of the spectrum where there's too much compression of that articular cartilage, and that extreme compression of the articular cartilage can cause damage to occur. So let's have a concept check. Which of the following is an anatomical component, is not an anatomical component of a synovial joint? We have articular cartilage, the joint cavity, an interosseous membrane, the fibrous capsule, and the synovial membrane. So what is not part of a synovial joint? We'll say 10 more seconds. 4, 6, 7, 8, 9, 10. Please go ahead and answer if you haven't answered yet. The correct answer is an interosseous membrane. And as we look at the interosseous membrane, the root word there is osseous, referring to bone. An interosseous membrane is that membrane that lines the medullary cavity or the marrow cavity of a long bone. And that is not part of a joint. So as a class, we did pretty respectful. And we have about 5 minutes left in class, but that's a really good stopping point. So we're going to go ahead and stop here for today. On Friday, we're going to do joint movements during class. Joint movements on Friday.